Hello, I am Sara Davis, and I'm a speech pathologist, and I was asked to speak to you today about vocal fold mobility impairments, specifically vocal fold paralysis and paresis. So I'm going to share my presentation with you. All right, like I mentioned, I'll be speaking with you about expanding your understanding of vocal fold mobility impairment. What is vocal fold paralysis? It is a voice disorder or a mobility impairment that occurs when one or both of the vocal folds do not open or close like they should. It can be unilateral, meaning one vocal fold does not move like it should, or bilateral, both can be paralyzed. Unilateral, again, one is paralyzed most often. When this occurs, the person may have trouble speaking or swallowing, depending on the position of the paralysis. Breathing problems are not as common as when both vocal folds are paralyzed. As mentioned below, bilateral vocal fold paralysis, both are paralyzed. When this occurs, it's often that they're paralyzed closer together, so the airway itself is too small or very small to tolerate without sounding like you're really struggling to breathe. And often this can be life-threatening without treatment. One thing to notice on this page is it does say, under unilateral vocal fold paralysis, the vocal folds can be paralyzed in 3 specific positions. It's really important to find out what position the vocal fold is paralyzed in, if you're the patient yourself, or if you're talking to someone who has this condition. The positions can be median, which means midline straight up and down, or paramedian, which means slightly open, usually about 1.5 millimeters from midline, or lateral, which is still further open from there. And again, this is usually further open at 3.5 millimeters away from midline or more. And this lateral position is worse for voice and swallowing because you've got one vocal fold that's stuck way out here. The other one can't reach it. If it's paralyzed at midline, one might be able to reach it. That could be better for voice and or swallowing. It could impact breathing a little. And when it's somewhere in between, paramedian, there could be a challenge with voice swallowing, probably not as much with breathing. But it's really important to know what position the vocal fold is paralyzed in. Vocal fold paresis, this just means a weakness, a weakened vocal fold movement, usually caused by a partial loss of nerve input. Paralysis, like we mentioned, is a complete absence of vocal fold movement caused by complete loss of nerve input. The paresis is just the weakness and certainly will impact voice, possibly breathing and swallowing, more often voice. Depending on the needs of the patient or if you're the person, vocal fold mobility impairment, some form of movement disorder or impairment, paralysis or paresis, can cause mild to significant difficulty. If you're a professional singer, even mild paresis or weakness can dramatically impact your career. But if you work in a job that requires very little voice use, you may experience minimal impact. These are quick little pictures. Unilateral one-sided paralysis is shown at the top. You can see the right side of the screen. The vocal fold appears to have reduced tone, kind of is shaped more like this instead of bulked up and smooth edge. And it is stuck in that more open position. And the other one, this is not a moving picture, but you can tell the other one is fairly normal. The one on the right, which is actually the left vocal fold, it's switched on the camera, but it's the right side of the screen is the one that is paralyzed. At the bottom, that's what bilateral paralysis looks like. And you can see this patient has much smaller than desired airway. It's important to discuss a little bit related to the nerve involved or nerves involved. Vocal fold mobility impairment can result from dysfunction of the nerves that control that region, the region of the voice box or larynx. There are 2 nerves usually involved, the recurrent laryngeal nerve, RLN, or the superior laryngeal nerve, SLN. The RLN carries signals to the laryngeal muscles that function in the movement of the vocal folds, as well as some function with adjusting tension to the vocal folds, and this affects pitch variability. Healthy recurrent laryngeal nerve function is very important for breathing, speaking, coughing, and swallowing, because again, this nerve controls all movement to the vocal folds. And coughing, swallowing, breathing, and speaking are very important, related to the movement of the vocal folds. They require movement. This nerve goes into the chest area and curves back into the neck till it reaches your larynx. So because this nerve is relatively long and takes a detour to the laryngeal region, there's a chance it can be damaged or compressed in surgeries or by tumors in the head and neck chest region. The superior laryngeal nerve carries signals to the cricothyroid muscle. This is the muscle that controls pitch. So it really impacts higher pitches and can make a big difference for singers who are trying to achieve higher pitches. This muscle adjusts tension to the vocal folds, especially again for those higher pitches. And an injury or damage to this nerve can cause an ability to increase pitch, especially higher notes, and especially relevant for singers. So what causes vocal fold mobility impairments? And often this is because of that, those nerves I mentioned, those impulses to the larynx are disrupted because of insults to these nerves, and that can cause paralysis, stuckness, or inability to move, or paresis, weakness of the muscles of the vocal folds. What causes vocal fold mobility impairments? There are actually several causes. We'll brush through the main ones, and there's still one at the end that's called idiopathic, which unfortunately means there is no reason they can figure out, which is very annoying, but it does happen. Surgery is a common culprit, and often on surgeries that occur near the head, neck, and chest. And most commonly, this could be thyroidectomy, removal of the thyroid, parathyroid surgery, heart surgery, cervical spine surgery, and occasionally intubations themselves. And that's when, for any surgery, you have a breathing tube inserted during the surgery. Sometimes this can impact the nerves as well. Neck or chest injury, trauma to this region, can injure the larynx itself and or the nerves that control the movement of the larynx. Tumors, these can be cancerous or non-cancerous, that grow in or around the muscles, cartilages, or nerves controlling the function of the larynx and cause mobility impairments to the vocal folds. Most often, this can be head, neck, chest related, thyroid nodules, thyroid masses or cancers, lung masses or nodules, or other head, neck, or chest related tumors or masses. Infections, some viral infections, Lyme disease, Epstein-Barr disease or virus, herpes even, COVID-19, or something as simple as a cold, an upper respiratory infection or virus. This can cause inflammation and directly damage or impact the nerves that control vocal fold movement. Neurological conditions, certain ones that involve nerve deterioration and damage, such as MS, Parkinson's disease, and or stroke, can lead to mobility impairment in the larynx. A stroke interrupts blood flow in the brain and can damage the part of the brain that sends messages to the larynx. Autoimmune diseases can cause this. That's because these diseases interfere with how nerves communicate with the muscles. Myasthenia gravis is a good example. This interference in this communication can lead to that impairment. Poisonous substances also, toxins, lead, mercury, arsenic, etc. These can harm nerve tissue and impact the nerves that control the vocal folds. And then there at the end, like I mentioned before, idiopathic. Unfortunately, sometimes we don't know the reason. Risk factors, kind of alluded to before, would be the need for throat or chest surgeries, any surgeries, because that intubation could be occurring, having a neurological condition, having a head, neck, or lung cancer or tumor or mass, having autoimmune diseases, and or exposure to toxins. The most common complaints related to a vocal fold mobility impairment include breathy or weak voice, hoarseness, vocal strain, vocal fatigue, noisy breathing, and what's called stridor. Might sound like when you're trying to inhale, could also sound like Darth Vader-ish, really audible inhalations, shortness of breath in general, loss of vocal pitch variation or reduced pitch range in general, especially noted for singers or people that navigate up higher in the pitches, even while speaking, choking or coughing while swallowing food, liquid, or even saliva or secretions, the need to take frequent breaths while speaking, inability to speak loudly, reduced vocal power or endurance or volume, reduced vocal endurance, like I mentioned, the loss of a gag reflex, ineffective coughing, reduced cough strength, and frequent throat clearing. Another thing that's common to voice that's actually not on here is what's called diplophonia. It just means the sound of two tones at once. This often can happen because the vocal folds are mismatched because of the mobility impairment. So they're not matching up as they should or vibrating as they should. And it can create that funky kind of two tones at once sound. So what does a vocal fold paralysis feel like? You will probably not feel like, my vocal fold is not moving, but you will definitely feel the impact or the effects of this. The feelings come across, like it mentioned, as a need to push the voice or vocal fatigue or reduced vocal endurance or volume too. Feelings of aspiration, food, liquid, or secretions going into the wrong pipe, and feelings of difficulty breathing, of course, feelings of mucus in the throat that is very difficult to clear or move. Can you speak with vocal fold paralysis? Yes, most people can, but the voice quality is likely dysphonic or abnormal, often characterized again by breathy, weak, strained, effortful, or diphthonic quality. You can also get winded while speaking. If the paralysis is more severe, you may have very minimal voice at all or lose it very easily. How is vocal fold paralysis or paresis diagnosed? First, if you notice a change in voice longer than 2 weeks, that should warrant a visit to a specialist, an ENT or otolaryngologist, but ideally a laryngologist. This is an ENT that's done specialized training in voice and also upper airway and swallowing. So this visit should include a laryngoscopy or a video stroboscopy. These two exams will visualize the larynx, the anatomy, the function, and if it involves that stroboscopy, this also will show vibration of the vocal folds, which is very, very important to determine if the vocal folds are closing, if there's an asymmetry, a vertical height difference. Lots of detail will tell us more information. Doctor can also order imaging studies, MRIs, CT scans. This can help with identifying abnormalities that can be causing that insult to the nerve that talks to the vocal folds and tells them to move or have reduced mobility. Doctors can also use what's called laryngeal electromyography or LEMG. This is really helpful actually for diagnosing paresis or paralysis because it's a system or a test that measures how the nerves control the muscles and the larynx by evaluating and recording the electrical impulses of the muscles. So it really will determine that movement disorder because it's looking directly at the muscles. Again, blood tests also could be another option and ordered by your doctor, especially if an autoimmune disease or an infection could be involved in the paralysis. The trifecta just means as a result of a vocal fold mobility impairment, you or the patient may have trouble speaking, so voice, swallowing, or even breathing, as we discussed. All of these in the trifecta are vital to life, vital to daily life, and vital to the movement of the vocal folds. So most of the time, all three, or certainly one of these, are affected by a mobility impairment. Severity does range. As mentioned, unilateral vocal fold paralysis can range from mild to severe, depending on where it's paralyzed. And mild cases certainly impact the voice. More severe cases can also negatively impact breathing and swallowing. Bilateral vocal fold paralysis can negatively impact breathing, as mentioned and shown to you before. When that space is so small instead of wide open airway, the patient, you or the patient, cannot breathe as efficiently as needed. So swallowing can also be affected though, because if the airway is always open, then food, liquid, or secretions can head in there, and that's called aspiration. So breathing and swallowing can be affected more dramatically in most cases with that bilateral vocal fold immobility. Treatment. So most common treatments involve voice therapy and temporary or permanent surgical interventions. Some people's voices will naturally recover sometime in the first year. So doctors will delay a permanent surgical option until at least a year has gone by. Within the first year, hopefully soon after diagnosis, the doctor could refer you or the patient to a speech pathologist who does specialize in voice for voice therapy. This could involve exercises or strategies to help with breath control, help with voice, help with the daily life and efficiency of voice. Voice therapy is a great idea if touch closure is achieved, as noted during a stroboscopy. If there's glottic insufficiency or incomplete closure, then usually the anatomy will need to be helped first via a temporary, what we call injection augmentation, which is just a little filler substance the doctor will usually input into the affected side, or if both sides are thin, they may consider both. This just means a little plumping of the vocal folds to help the anatomy, to help the vocal folds touch better. And so this will help with voice and swallowing and more effective voice therapy if there is never a true vocal fold closure found on the stroboscopy. So the team of surgical, temporary with an injection, and voice therapy interventions are excellent in terms of during the first year. They can help reduce your symptoms while waiting for the paralysis to resolve. But if a year has gone by and the paralysis is permanent, then there is a more common surgical procedure that's called a medialization thyroplasty or laryngoplasty, which involves inserting a more permanent implant to improve that vocal fold closure for better voice and swallowing. But there is a chance the provider may need to revise the surgery if the implant migrates or moves over time, but this is not that common. Stitches can also be used to reposition the laryngeal cartilage and bring the vocal folds closer together if needed. So there are several options: temporary, surgical, which would be the injection, and more permanent would be more the implant or stitches to reposition cartilage to allow goals to be reached depending on the patient and the doctor. If we're talking about a bilateral vocal fold paralysis, a tracheotomy, which is short called a trach, may be required to ensure there's an adequate airway. So imagine that picture I showed you before with really small opening. If we don't think the patient is going to get any more airway than that, or even if it's smaller than that, a trach may be required. And this is a little cut that's made in the front of the neck, and a breathing tube or trach tube is inserted through the opening, and breathing now happens through that tube. And that inability to breathe is dramatically reduced because we've created, or the doctor has created, an airway. Speech pathology intervention is still really helpful at this point, because we can teach the patient how to use voice again, how to prioritize using a speaking valve on the trach, how to restore better swallow function. Even though the trach is there, using that valve can really help with swallowing, and how to properly care for the trach itself. This is a little video that just highlights the collaborative approach to vocal fold paralysis. This patient's paralysis, as seen on the right side of the screen, it's actually the left side of the body. And even though that other side is trying so hard to reach it, there's never any closure achieved. So this patient isn't the best candidate for voice therapy yet. You'll see as we keep watching, eventually the patient does get an injection to that affected side, and you'll see the difference. Right now, we're still seeing what happens before that. Also, vertical height difference, asymmetry. Now we see after the injection, the difference, right? So, although not perfect, much improved. And this patient is now an excellent candidate for some voice therapy, as we're hopefully waiting on that nerve to wake back up. Can a paralyzed vocal fold be repaired? Well, we discussed treatment options that can improve the symptoms related to the paralysis or paresis. But if a year's gone by, it can be expected the nerve may not be repaired or wake back up itself. So there is a reinnervation surgery option where the doctor or surgeon takes a nerve that connects that nerve to other muscles in your neck and reattaches it to the nerve that controls the vocal folds. So it can be done, and there's still research going on about this as well. I just included a few slides about research related to vocal fold mobility impairment. You may find some of it interesting. Ones I like to mention, and the citations are also at the end of this presentation, but cough strength improves after injection augmentation. That's excellent because we want a good cough in case we aspirate, and it also can indicate improved respiratory support for voice. So excellent for cough strength is injection augmentation. As we improve the vocal fold and how it can touch the other one, we can improve cough. That's the first study there. Second one talks about if somebody has a one-sided vocal fold paralysis, the other side exhibits faster squeezing inward, and the other arytenoid, which is the joint cartilage, it's got better metabolism too. So we know that other side is overcompensating a lot. We know that we often see it on a video stroboscopy. Patient might actually feel that too, but we see it in this study. So it's always interesting to have research to show what we already know. A laryngeal electromyography, so that LEMG, that's useful in diagnosing neuromuscular dysfunction of the larynx, and it is included in best practice along with stroboscopy. So this last study shows that. It also found that recurrent laryngeal nerve lesions are more likely to present with a lateral positioning of the paralysis, but it doesn't occur in all cases. Significant improvement of voice quality and quality of life after voice therapy is often found in a reasonable goal in patients with one-sided vocal fold paralysis. So that's awesome. A long duration, up to 12 months of acceptable voice quality was achieved by augmentation, injection with something called Restylane if the glottal gap was 1 millimeter or less. So not a huge one, but found with that augmentation to improve somewhat of a long duration of voice improvement. And this was also combined with voice therapy, and it's temporary. So as we're waiting on that nerve to hopefully recover, this is a great option. And the third study on this page shows voice therapy is effective in patients with one-sided vocal fold paralysis, and its benefits are sustained over time. Early referral for voice therapy seems to be associated with greater benefit, but quality of life is also improved for patients despite delayed treatment. Voice therapy following injection laryngoplasty. So that injection I mentioned, temporary, is beneficial to patients with one-sided vocal fold paralysis. Combined treatment can help to maintain improved voice quality for more than 6 months after the injection. With the exception of severe true vocal fold range of motion disturbance, there seems to be poor validity of laryngoscopic findings in predicting the affected side in vocal fold paresis. This means when there's a weakness assumed, the validity of medical professionals looking at stroboscopy is not always perfect to determine the weak side. And that was new research. So it's better that we do that LEMG to truly determine that clinical diagnosis of the paresis. And the last study just kind of shows a recommended program for unilateral one-sided vocal fold paralysis or paresis after thyroidectomy. And this study did recommend injection first and voice therapy before the 12 months, but after that, a more permanent decision. And they also have recommendations for bilateral vocal fold paralysis as well, and you can see that underneath. Lastly, this is another recommendation kind of just showing that this study found after a thyroid surgical procedure. This study found that permanent surgical intervention could be considered after 6 months because recovery of the nerve was unlikely. However, in most cases, it's given up to a year normally. But for patients with other surgeries or reasoning for unilateral one-sided vocal fold paralysis, the 1 year was a definite before a permanent option was decided. So lastly, these are great questions to ask your doctor or encourage someone else to ask their doctor about vocal fold mobility impairment if it was a diagnosis. What is the cause? Is the vocal fold completely paralyzed or partially? Or is there just a weakness, paresis? In what position is the vocal fold stuck? Midline, median, paramedian, or lateral? This is really good information. Does vocal fold paralysis affect the ability to swallow properly? What are the chances of recovery if you do not pursue any treatment? And or how can you pursue treatment quickly? You need your voice for your job. What can you do? And or what are the chances of complications, inability to breathe, aspiration, pneumonia, etc., if you do not pursue any treatment? But again, hopefully based on this presentation and the research I mentioned, there are a lot of great reasons to include voice therapy and other temporary or permanent surgical options. Here are my references, and please let me know if you have any questions. I am honored to provide you this information, and I am so thankful for your support to all of our members. And again, have a wonderful day. Thank you for listening.